All right. So we're going to talk about some registry questions. This is very much a two-way street. Really can't, I don't want this to be a lecture. We're going to take a couple questions. I know that one of you has class in about 15 minutes, so we'll try to make this short, but I want to hit on a couple of questions and let you kind of see how they break apart. So the first one we're going to talk about is question number 7, if y'all can see it on your screen. I'm going to read it to you. It says you are evaluating a 180-pound, 22-year-old male who is bleeding severely from a lacerated radial artery. So think about where that's at. The patient has lost approximately 1 pint of blood so far, so you should expect to find, and then it gives you some options. Now, ultimately here, the big thing is we're dealing with blood loss, right? So nothing in the question has said anything about fixing that problem. It's asking you about what you might expect to see, and then so now you've got 4 options that go for that. If you think about what you learned in shock, if we start trying to compensate for blood loss, what is that going to do to our vital signs?
I believe it's going to be B, correct?
All right, so increased pulse, decreased blood pressure, and rapid respirations. So all right, let's look at the options. Normal pulse, we know that's not going to be right. When we compensate, pulse is going to climb. So that knocks A out. B, C, and D have an increased pulse, and then now we have decreased blood pressure, decreased systolic, or an increased systolic, and then our respirations change. The pulse is increasing to try to keep the blood pressure up. If we actually see a decrease in blood pressure, that means you're pretty far down the road. And a lot of times that's either going to be because they've been in shock for a while or because they've lost a whole lot of blood. Now, a pint, not really that, I mean, it's a lot, yes, don't get me wrong, but it's not like they bled out. So you're going to see some mild compensation. You're going to get that high pulse. You're going to get a little bit of an increase in systolic blood pressure, which is okay. The diastolic, what will happen and this can be a whole other class in itself, we can go over. The blood pressure is going to start to like separate, right? Because remember, your bottom number is how much pressure is in the system at all times or between beats. So that number, if you're losing blood, it's going to drop. There's just not as much blood in the system. The heart's beating faster. The heart is controlling the systolic because that top number is what's in the system when the heart beats. So that number will climb. So you're going to start off, you're going to see the blood pressure start to spread apart. And then when the body wears out, this number starts to drop because the the pulse is going down, and then everything starts to crash out. But I like where you were going with that. So increased pulse, yes. Decreased blood pressure would be a more severe case, or if this were to keep going for a long amount of time. And then the rapid respirations is also would be correct. So it comes down to, if we look at the respirations, C says normal. It's not a compensation. If you're going to compensate, your breathing's going to climb with your pulse. They always go hand in hand. If your pulse goes up, your breathing is going to go up. So if that happens, if you look at this option, C says increased pulse, but normal respirations, that's a mismatch. So that one can be thrown out. But good guess. So that answer is actually D, and it's because the blood pressure is going to climb a little bit with it at first as well. If it's dropping, you would have lost a lot more blood, or it would have said somewhere in the question that he had already been in that state for a while or something of that sort.
Gotcha.
Look at all right, let's look, well, have y'all gone over cardiology yet? Cardiac emergencies in the EMT basic?
Yes, I think so.
Okay. All right, let's see. I want to find one that's actually, give me a sec. I'm not going to ask you all that question. I want to find one that's actually about your assessment.
Sorry, y'all hear the traffic. I live on a highway,
Oh, that's fine.
but it's still quieter out here than it is inside the house.
While I'm digging up a question, what's going on in the house? Party?
My kids. No, my kids are just playing. They finished
Oh.
homework today, so they're in play mode.
I got you. I tell you what, I'm going to do this. I had a question from a student last night that was a good one for breaking things down because it was a scenario question. Let me find that and we'll talk about that one. All right, so I'm going to read the scenario to you and I want you to think about, just picture it in your head. First of all, picture the scenario. Then we're going to picture the assessment. All right, so in a head-on collision, a poorly restrained 18-month-old child, so we're talking about a 1.5-year-old baby here, became loose from the car seat, causing him to strike the back of the front passenger seat. He presents supine on the car floor, tachypnic with cyanotic cool skin. He doesn't cry and he grunts when he breathes. Lung sounds are diminished over the left side, and you notice crepitus of the rib cage over that side. Now, I don't need you guys to be through trauma yet on the EMT side, because even though this is a trauma call, you'll see when I read the options to you that nothing in here is about fixing any trauma. All right, so the question, first of all that, and the question wants you to answer, what are you going to do basically first? All right, what's your top priority of the 4 options that are there? We have immobilize the patient on a pediatric backboard and lay him on the affected side. That's the first option. The next 3 options have to do with breathing. So there's a hint right there. Assist ventilations with a pediatric back valve mask. Administer high flow oxygen via a pediatric non-rebreather, or administer low flow oxygen via a pediatric nasal cannula. So we are going to either bag him and give him oxygen. We are going to use a non-rebreather to give him oxygen, or a nasal cannula. So with those in mind, let's go back and look at this. In a head-on collision, a poorly restrained 18-month-old child became loose from his car seat, causing him to strike the back of the front passenger seat. Presents supine on the car floor, tachypnic with cyanotic cool skin. He doesn't cry and he grunts when he breathes. Lung sounds are diminished over the left side, and you note crepitus of the rib cage over that side. You should. Now, some questions in the registry are going to be very tricky. All 4 options are going to look right because they technically are. All 4 options may be in your scenario. So how do you know which one is the one that it wants you to get? You know, if all 4 options are in your assessment, you're going to do every one of them. How do you know which one's next or which one you need to do? This is where people usually get tripped up. What I want you guys to do is don't look at your assessments as being just for psychomotor skills. Take that knowledge and how those assessments lay out, take them with you into this test, because when you get these scenario questions, what they're doing is they're testing you in a cognitive sense, like a tabletop exercise. Where are you in your assessment? So let's go through this, all right? First thing we need to do in every assessment is our scene size up. And we can beat that to death. I'm not really gonna, like I said, I don't wanna make it a class on that. We've already gone through it. But you know that your BSI and your scene safety is gonna be the first thing. If it doesn't specify in the question that you've taken those steps and you see it as an answer, that's gonna be your answer. Because it's the first 2 steps, right? If you see it in the options, but it says you already did it in the question, then that's not your first step because you've already done it. So don't fall for that trick. All right. The next 2 steps after taking care of yourself is surveying the scene, doing a quick triage. So how many patients do you have? Blah, blah, blah. And you just, do you need additional resources? What's your mechanism of injury, your nature of illness? And is there C-spine involved in this? Now, of the 4 options, none of these options have to do with anything in your size up, but I want you to always start with BSI, scene safety, and go through that, because sometimes they will, right? I don't want you to miss a size up answer because you went straight to trying to fix something in like a broken bone or something of that sort. That yes, you would do it, but that may not be your next step. So you go through your size up. Everything about it is either in the question or irrelevant because it's not an answer option anyway. All right, so now we get to our primary, and the primary, I want you guys to remember, has to be done in order, right? So the first thing you do when you show up to your patient is consider their level of consciousness. If they're unconscious, we're going to take a pulse. So let's go back and look at the question. He's supine on the car floor, tachypnic, which means what? What's tachypnea? Y'all still with me?
Yeah, I'm still here.
Okay. So tachypnea, anything, remember tachy means fast.
Fast.
So if you're at, and then the pnea, or that's just the root of the word, but tachypnea just means fast breathing. So you've got a baby supine on the car floor that's breathing really fast, but he's cyanotic. So he's got blue on his fingertips, blue around the lips, and cool skin. All right. So now we know we've also got signs of shock because he's breathing fast. He's cyanotic and his skin is cool. He doesn't cry, which in the real world, a baby should be crying, right? If something's wrong. So if the baby's not crying in this situation, that's a bad thing. And he grunts when he breathes. So now we also have some breathing issues. Lung sounds are diminished over the left side, and you notice crepitus of the rib cage. So let me ask you this: with that kind of knowledge, do you think that baby is good to breathe on its own, or do you think you need to provide breaths?
I'd bag him.
Absolutely. So now, because of that, you know that the option to administer high flow with a non-rebreather or low flow with a nasal cannula, they're out. That only leaves you with the assistive ventilations with a pediatric bag valve mask. I'll give you guys another quick one. I'm going to make this up off the top of my head, so bear with me. All right. You show up to, we're going to say you show up to a 72-year-old male that is altered level of consciousness outside of the Mexican restaurant in your local hometown. He's walking around looking at people, doesn't look like he knows where he's at. And somebody just out of concern called 911 for you to get there. So you show up and there's an off-duty firefighter, EMR, that's there, and he is telling you that the last thing that he did was introduce himself to the patient, and the patient said blue, like that was his answer. And you have 4 options as to what is going to be your next step. So you can either, and we'll say you're already wearing your gloves, so you can hook him up on oxygen with a non-rebreather. You can bag him. You can check his blood glucose. Or you can get his history. So with those 4 options for that scenario, what would be your first step? Any ideas? It's okay to be wrong. This isn't a test.
Maybe the blood glucose, because he's already breathing like adequately.
Okay.
I guess.
All right. So, and that's kind of where these questions kind of start to trick you, is because you're going to do everything that I mentioned. Well, almost. You're not going to, there's no sense in bagging him, but you're going to give him oxygen, right? You're going to check his glucose because he's altered. You're going to get a history. All these things are in your assessment, but you're picking up where an EMR left off. And when you take this test, remember that the registry is not going to make you assume that any trained responder is wrong, especially not one of their own. So if you do something that, if you pick up where another EMT left off or an EMR left off, you can assume that they did everything to that point and they did it fine, and you're going to pick up where they leave off. So if the EMR says that he got was he tried to introduce himself to the patient, and the patient responded with a word that didn't make any sense to the, to the scenario. What did he do? What if you were to see that play out in the real world, knowing about your primary assessment, what steps can you deduce are good on that? What's the first step of the primary?
The level of consciousness.
Level of consciousness. Good. So he's alert in that he's answering questions, right? He just threw out the wrong word. So he's alert, but he's confused. All right. So we've got that covered. Now he said that the patient said a word. So airway is good. And then that leaves you with, what's the next step after A? In your primary. So you did LOC, A, and then what?
The circulation.
Nope, you don't go from A to C. There's a letter in between there.
Oh, breathing.
There you go. All right. If a patient's alert, you can pretty well assume that unless some special condition is going on, like when we're dealing with stroke patients, you can assume that an alert patient is going to have a good airway. But their breathing is always going to be that's going to be something that you're probably going to want to do something every single time you come across this. And if you look at your assessment, it actually says as a critical failure to consider and ultimately give O2. So I'm going to pause the scenario and ask you this: when is the perfect time to give somebody oxygen to satisfy that? How early in your assessment can you give oxygen?
After the scene size up.
Pretty much, right? But on a specific letter, it's going to be B. B has to do with breathing. So you're done. You now know that you have that route. Now we're worried about the actual switching of the gases in the alveoli. So you need oxygen in the lungs to get the CO2 out of the body. So in the B portion of your primary, you can go ahead and be giving oxygen, even if it's just low flow. If you feel like your patient doesn't need a non-rebreather or to be bagged or whatever, that's fine. Don't do it. You can give them a non-nasal cannula. And then when you get your vital signs, you can always either step it up or dial it back, or even just take it off if you need to, based on their percentage. But when they're altered like that, the brain needs two things to survive. It needs two things to work right. It needs oxygen and glucose. If it's altered, it's gonna wind up boiling down a lot of times to one of those is not where it needs to be. So the sooner we give it, the better. And oxygen is great. We need it to live. If you, like I said, if it winds up being that he doesn't need it, you can always take it off. But you would give that in B. So on a patient, in the 9 times out of 10 on a medical call, that's what you'll do is you're going to make sure they have an airway. Then you're going to put something in it, put oxygen in it. So in that case, that would have been your answer, because when if you know you need to do a glucose stick, but glucose is a vital sign, right? So when does that happen? What category, like what major section of our assessment does the vital signs happen in?
The secondary.
Secondary, good. All right. And then what else is, oh, history. History is secondary as well, right? So consider this too. Your scene size up, I want you to know it in order. That's a personal thing. I think that if I can get students to learn their scene size up in order, it just builds that momentum and you fly right through. You're gonna hit everything. You've got that confidence that you got everything in the size up. You're not sitting here trying to think about what's next in the primary while you're trying to figure out what you forgot in the size up. So get that in order. You must get the primary in order. There's a reason why they teach it as ABC. It's not just a mnemonic to remember what you need to check. It's in that order. The registry will give you the questions with the expectation they're actually checking to see if you'll do that in order. So it's level of consciousness, and then it's either going to be ABC or CAB, depending on if it's a live person or if you're doing CPR. Then you get your general impression and you move into your secondary. Your secondary, you're in control of how you want to do that, whether you do vitals first, histories first, whatever, that's fine. And because of that, the registry is not going to ask you what's next in that section of your assessment, because it's entirely up to you. There's no way to test that. Whenever you see a question that says, what's your next step? Usually it's, if you step back and look at that question, most of the time it's because it's asking you a question that has some kind of a primary intervention that hasn't been done yet. And it wants to know that you recognize that and that you do it. So if you're looking at 4 answers and they look like they're absolutely right, all 4 of them, you know, it's a history. Well, I'm going to get a history. I'm going to get my vital signs. I'm going to give them oxygen, and I'm going to, I don't know, put an OPA in him because he's completely unconscious. Of those 4 options, what's the first one you're going to do? You're either gonna, do you fix A, B, or vital signs first?
Airway.
Airway, good. Yeah, it's A before B, B before C. Remember, and so it's got to be in that order. Now, Rose, I don't think you were here when we did this question, so I'm gonna go back to it. And let's see if it makes more sense with what we were saying too for you, Leah. So this is the car wreck with the baby. In a head-on collision, a poorly restrained 18-month-old child became loosed from his car seat, causing him to strike the back of the front passenger seat. So he comes out of the seat, hits the one in front, and is now found lying supine on the car floor behind the passenger seat. He's tachypnic, which means he's breathing fast. He's cyanotic, which means he's got blue skin, and he has cool skin. So it's not warm. If he's cool, clammy, and cyanotic, that means there's no blood flow to the skin, right? So that blood's got to go somewhere. He doesn't cry, which is unusual for an 18-month-old baby that just got hit. And he grunts when he breathes. Lung sounds are diminished over the left side, and you note crepitus of the rib cage over that side. You should, and it's going to give you 4 options. So your first option is immobilize the patient on a pediatric backboard and lay him on the affected side. We probably would do that, right? But that may not be the first thing that we're going to do. Next up, we have assistive ventilations with a pediatric back valve mask. We have administer high flow oxygen via a pediatric non-rebreather. And we have administer low flow oxygen via a pediatric nasal cannula. So we've got 3 options that involve breathing. 1, you're going to bag them. And then another one is you're going to use a non-rebreather or a nasal cannula. All right, so now if we're talking about what's next, let's look at this in the grouping. Are we going to do oxygen therapy first, or are we going to do packaging him on a backboard and putting him in the truck first? If you think about your assessment, what comes first when you're tricking down those? Go ahead, Leah. I saw you unmute.
The airway.
Yeah, so airway, breathing, circulation, right? That's going to come first. You don't package your patient until you get past the secondary, especially in trauma, because we don't want to move them until we know what their injuries are. So anything about immobilizing on a backboard and all that, that's way down the line. All right, so now we're looking at the breathing options. With the baby in this condition, let's go back and take a look at what they described that you're dealing with. You have a tachypnic baby, so he's breathing fast, right? He should be good, but he's cyanotic and he's got cool skin. So he's got a high breathing rate, but he's not getting good respirations. He's not crying, even though he should be in this situation. And he grunts when he breathes. His lung sound is diminished over the left side. And he's got crepitus of the rib cage on that side. So does it sound like to you as an EMT that this child can breathe, that we can, you know what, this child's breathing well enough on their own, all we need to do is give them oxygen? Or might have some problems with the actual mechanics going on here, maybe we should bag him?
Bag him.
Bag him, yep. Always ask yourself that when you're looking at how you're going to deliver the oxygen. Go back and see what the question says about the state of the patient's breathing. They might be breathing 15, 16 times a minute, but if you see signs that despite that, they're having a problem breathing, they're having that respiratory, cyanosis or cool, clammy skin, that kind of thing. They may not, basically you can look at it like you can't really trust them to breathe on their own, because if they were able to do that, they wouldn't have all those bad symptoms. So going back and looking at these options, you had the BVM, and then you had non-rebreather and a cannula. The non-rebreather and a cannula require that the patient is able to ventilate well enough on their own. All right, but obvious signs of shock, diminished lung sounds means that they probably have either some serious injuries around the lungs that's muffling your ability to hear, or they popped a lung. And with the fact that you hear crepitus in the bones, which means that the bones are grinding, chances are they popped a lung. So this patient does not really have the ability to breathe very effectively on their own. So you can rule out the cannula and the non-rebreather because you're going to use a bag. That's the only option that's left at that point. So again, you've got 4 options and they all look really well. They all look good. One, you'll do it. It's wrong though, because you're going to do it later in the assessment. And then of the other 3, they're all basically just questioning, okay, so we know we're going to give oxygen, but how are you going to give it? That's a quick, easy way to kind of think of that. So, you get to airway, everything in your primary, you know that you need it. If you don't have it, you got to give it. So when you get to airway, we do a head tilt, chin lift, or a jaw thrust. So you'll learn when you get to the trauma chapter. And that creates the airway. And then you're going to put a patent airway in that makes it stay once you let it go, right? So an OPA or an NPA, you've got to do your intervention in that spot. So if you get options about an unresponsive patient, and the question alludes to the fact that they don't have a patent airway, and you've got the following options, or one is give them an airway, another one is give them oxygen by a back valve mask, which would absolutely be right. One may be get a full set of vital signs, and another one is bandage a moderate bleed. Every one of those would happen. They're all right answers, but the airway comes first. So the OPA is your answer. The rest of them would happen after that. That's the big way to break down those questions when it puts you in a scenario and it's like, what's your next step? Picture your scenario in your head, and then when you go to take the registry, they'll give you a piece of paper. I highly suggest you use it. What I would do is write down 2 things. Write out your assessment all the way down from BSIC and safety all the way to reassessing your vital signs every 5 or 15 minutes. Just from memory, write it in order. And then you can, if you want to write it down, if you don't quite have it memorized all the way yet, is write down your vital signs, particularly for infants and children. You're going to get really good at knowing your vital signs for adults, because we're going to beat it like beat a dead horse with it all through the class. And then at the very end, you're going to get pediatrics, and it's just 1 chapter, and you're going to learn about pediatric vital signs and everything you're going to do for pediatrics. And it's not, they don't draw it out like, that's just the way the class works. So write that down. Write down what those vital signs are, so that when you get a question and it says you have a child, this 18-month-old male with we'll say a heart rate of 60. All right. Is that good or bad?
Bad.
That's bad. Now, I know that you guys haven't hit pediatrics yet. But a heart rate of 60 in a baby is taught as being horrible in just basic CPR. Anything 60 and under for a baby is compressions. Even though they have a pulse, you're still doing CPR. That's how bad that is. All right. So, but with the rest of the vital signs, they don't really, they don't talk about respiratory rates outside for infants outside of the pediatrics. So write that stuff down. That way you've got it. You've basically made your quick reference and you don't have to try to remember it. If it's something that you just put to short-term memory, walk into the registry, get that piece of paper before you even answer your first question. Just write out your own cheat sheet so that you can reference things as you go through. And remember that your primary has to be in order. Those questions about what's next, that's what they're actually questioning you on, is making sure that you know A before B, B before C. Vital signs and history can come later on, and it's in any order you want. So the secondary assessment is, they're not going to give you what's next questions that are somewhere stuck in the middle of your secondary, because you can do those in any order. All those what's next questions typically are going to be about your primary. Any questions on how the scenarios would work? Have you all been taking any practice registry test questions throughout the course?
No.
I mean, honestly, I don't blame you, but I do recommend it. All right, you can get those apps. There's a couple of free ones out there that you can get on your phone. And I want to say it's let me find, I got it. Hold on, I'll show you what it is. The one that I'm thinking of right off the bat, you can actually pick your topic. So even though you're only halfway through the course, you're over the hump now, but you haven't touched trauma yet. So if you want to just stick to the stuff you've already gone over, you can pick those topics and do registry questions on that and not worry about the stuff you haven't gotten to yet. But it's this icon right there. Oops, it says EMS. Has like a little compass on it. That's the one. That's actually probably the best one I've seen. I mean, it's not the fanciest looking app, but the questions on it are very good. And you have a lot of control over what topics you want to go over, like I was saying. So check that out. Use it throughout the course. Get a Master Your Medics account, the masteryourmedics.com. They're a fantastic group. Ask your instructors. Use Discord. All of the instructors, the AEMT instructor, myself, Chris, all the skills lab instructors, we're all in there. We'll go over stuff with you as well. So if you try one of these questions and it just throws you for a loop, put it in Discord. We can talk about it. We'll break it apart and help some other people as well. What about both of y'all are in the EMT basic course, correct?
Yeah.
Yes.
Okay. All right. How are y'all feeling with the medical emergencies so far? I know y'all said y'all did go over cardiac emergencies, correct? Did Chris teach y'all MONA and FONA, the acronym? I'm gonna assume no.
I think so, but I don't think I remember it. I think it's in the book though, right?
It probably is. Yeah, it's not something that we made up. They teach that. That's it's a really good way to remember what to do for a heart patient. So the M and the F is paramedic level. That's morphine and fentanyl. That's where they push it through the IV and it's a pain reliever. But the other three options you can do as an EMT. So O is oxygen, N is nitro, and A is aspirin. Now, without getting into the dosages or anything like that, let me ask you this. What order do you think you'd be able to give those in you know, following your assessment? If you're gonna deal with a cardiac patient and give those three things, which one are you gonna give first? If you give everything as soon as you're able.
Oxygen.
Oxygen, right? You can give that in the primary. All right. So now that leaves you with nitro and aspirin. Which one do you think you can give next?
Nitro?
It's a 50-50 shot, but it'll be aspirin. So thinking about, all right, what do you need to give nitro? What information do you need?
Do they already have the prescription?
Okay, so you want to know, now you want to know this medical history, right? Medications. What else?
Allergies.
Allergies. All right, so as you can see now, we have to get a sample history basically as one thing before we give a nitro. What else do we need? Let me ask it to you this way. If your patient has a blood pressure of 80/40, will you give him nitro?
You gotta take their vitals first.
Right. Yeah, because his blood pressure matters. So what's the minimum? What's the lowest their blood pressure can be before you decide you can't give them nitro anymore? Like I said earlier, it's okay to be wrong. All right, this is still class. It's not a lecture, but it is still learning. Systolic blood pressure needs to be at least 100. Did y'all remember hearing that in class? So it's got to be a 3-digit systolic, because if you think about the way that nitro works, it dilates the blood vessels. It's a smooth muscle relaxer. If their blood pressure is already too low and we make the pipes bigger, we can crash them out. So a safe blood pressure range is anything over 100. That way, when it does dilate the blood vessels and the pressure drops, it's at least high enough to support that. But my point in that is oxygen you can give in your primary. Aspirin, the only thing that we really worry about with aspirin is if they're hypersensitive to it. And you can just ask that question while you're pulling it out of the little jar. But nitro, you got to know everything about your patient at that before you hand them nitro. You got to, you know, are they prescribed it? Have they already taken it? Are they taking anything else? You know, like male enhancement, Viagra, Cialis, all that stuff. So we got to have a sample history, and we got to know their blood pressure. So now we got to have their vitals as well. Nitro is one of the last things. You'll already be done with your assessment, and then you're gonna be like, all right, I've run out of things to check. Let's go ahead and consider nitro. And then you would call, as an EMT, you would call med control and get permission to give it. But if you try to call too soon and you don't have all the answers, med control is not going to be real happy with you. So that's a end of the road thing. The reason that I bring that up is MONA and FONA is an acronym to remember what to do in a cardiac arrest patient, but you don't do them in that order, right? If you were a paramedic, you're not going to start the day off pumping them full of fentanyl either. You're going to have to get some information before you do that. So that's not the first step. Oxygen would be the first step. Nitro would be the last step, especially at y'all's level. And aspirin can kind of happen toward the beginning of the secondary. So it's out of order. It's just easy to remember. But your primary assessment is not. Your primary assessment is set in stone, step 1, step 2, step 3. It must be A before B, B before C, unless it's a cardiac arrest, and then you'll move C to the beginning. And so as long as you can keep that in mind, that your primary is set in order, when you're reading those questions with the registry, you're going to see when you're looking at it and everybody's like, well, that question's got 4 right answers and you got to pick the most right. That's because it's asking you for what's next. Where are you at in your assessment? To kind of determine how that would go. Have y'all gone over allergic reactions yet?
Yes.
Okay. What is the biggest concern with allergic reactions? As far as our patient's ability to have a pulse, be able to breathe, you know, dealing with our primary, what's the biggest thing that we worry about losing when we have an anaphylactic level response to something like a major allergic reaction, not just I touched poison ivy and I've got red bumps everywhere?
Isn't it like, I don't know, you go. Isn't it like airway obstruction or something? I don't know. Yeah.
Absolutely. Yeah. Oh yeah. You're running into the same kind of problem as if they swallowed a piece of steak whole, right? You've got an occluded airway. The only difference is that they didn't swallow it. There's nothing for you to Heimlich maneuver out of them. When we're dealing with an allergic reaction, the biggest problem is that the airway itself shuts off. And I'm not trying to quiz Chris's teaching with it, but if you think about how, like, what's happening when you have that reaction, you get this. An allergic reaction by definition is an overreaction of the body trying to fight off an invader. So you get something inside of you, some kind of toxin, be it from a bee sting or a peanut, if you have peanut allergies, that kind of thing, and your body is like, okay, I don't like this. It needs to go. So the body's way of doing that is sending the white blood cell army after it. The body's way of doing that is to expand the blood vessels to allow more blood flow. The problem with that is that the way that the body either expands, whatever the body does with the blood vessels, it was going to do the opposite with the airway. All right, so if the blood vessels get bigger, which is what the body's trying to do, to get more blood flow, you know, if you ever took an anatomy course, or if you've ever seen pictures of the blood cells, your red blood cells could be the size of a pencil eraser. And then next to them, the white blood cell looks like a $50 piece. I mean, they're giant. So to get a lot of them through the system, the blood vessels have to get really, really wide. And if this is an overreaction, which is what an allergic reaction is, that means they're going to get bigger than they need to be, right? The body is like, nope, we don't need 3 lanes. We want a 12-lane superhighway. But to open up your blood vessels that wide, the opposite's happening to your airway. The airway is getting tighter and tighter and tighter. And that's where we run into the problem. That's what you're actually responding to. So when people hit themselves with EpiPens, an EpiPen uses epinephrine, that's where it gets its name from, and is causing the opposite reaction. It's epinephrine causes the blood vessels to constrict, which then in turn makes the airway open back up. The only problem with that is that they don't last very long. So if that's the level of reaction they're having, you hit them with an EpiPen, you've bought yourself 3 to 5 minutes of relief. And then if they're still having their reaction, because it doesn't cure it, they're still having their reaction, they're going to start having that problem again. You have to hit them a second time with an EpiPen. Hopefully paramedics are en route, or you happen to be right next door to the hospital, you know, something of that sort, so that they can get a longer treatment. But with allergic reactions, I want you guys to think about what's happening there. So your biggest concern is airway. All right. So if you have an allergic reaction, if that's your scenario, and you picture yourself in your assessment, what are we trying to treat? What's your threat? We just talked about it. Is the problem the wide blood vessels, or is the problem the constricted airway?
Constricted
Airway.
Airway, right. So our problem is airway. All right, we'll just say that for the moment. Allergic reaction, airway. That's what you're fighting to save. So think about what we have for that. OPAs and NPAs, in this case, are more harm than good, right? You're taking an already clenched down airway and you're sticking something solid in there, which causes even more occlusion. So that's not the tools we're going to use. We're going to use epinephrine. You hit them with an EpiPen, it opens their airway up. That's what you're trying to do. Now, that being said, where in your assessment are you going to give that EpiPen?
Can't that be for airway? Because it constricts it and allows breathing.
Absolutely. That is, in fact, that is exactly where you want to do it. So if you'll do this when you go to your psychomotor exam, if they give you, because you're going to do one medical, one trauma, one BLS. That medical could be anything you guys have learned. It may be cardiac. We try not to use cardiac just because it's so in depth. It usually trips people up. That's not what we're not out to play gotcha. All right. But I want you to be ready for that as well. A lot of times we'll use diabetics or allergic reactions because they require you to think about what you're doing. They're immediate life threats. And I don't want you going through your entire assessment before you decide to give an EpiPen. So if it's an allergic reaction, you get through your size up. You always get through your size up, no matter what it is, before you do any interventions. Your interventions can start with your primary assessment. Your seeing size up is all about making sure that you're safe and making sure you're working on the right patient. So if it's an allergic reaction and they've got a clenched up airway, or it's a CHF patient that's lost their airway, COPD patient that's lost their airway, you want to fix the airway when you get to A. So allergic reaction patients, that's when you're going to hit them with the EpiPen. You're going to walk up and be like, all right, level of consciousness. Cool. Airway. Oh, they don't have one. Hit them with the Epi. All right. Then you can move on to breathing. When we give oxygen, if you want to give oxygen at that point, check their circulation because now you're at C, and then move on into your assessment. But those life-saving interventions like that, give them in the primary. All right. What else? Have y'all gone over strokes? How confident are y'all with strokes?
Probably not that confident.
It's all right. And look, like none of this, you're not expected to be masters. You're expected to just be competent. So it's like learning a new language, right? And you say, hey, hello, and everything, but you can't really hold a science class in Spanish unless you're good at that. So let's talk about strokes. First of all, what is a stroke? What's happening? What organ or system is being affected in a stroke?
Your brain.
Brain, right? All right. And that's going to be, in the context of a stroke, that's going to be one of two things that's causing that issue. It really just boils down to blood flow. All right. Either the blood is occluded, something has blocked the vein. There's a car wreck on the street somewhere, and the blood can't get past it. That's one. The other one is that we had a sinkhole or a bridge fell out and everything is just flying out and it's not staying in the vasculature. So you're either bleeding it out or it's just blocked, right? But ultimately it winds up being that a certain part of the brain is not getting the oxygen that it needs because the blood's not able to get there. So that being said, and I don't want to, because we're looking at this from an assessment standpoint, so I'm not going to go way off in the weeds of figuring out which one it is. But when you start your assessment, is there anything in your size up that involves an intervention? Are you going to do anything for a stroke in your size up? Oh, you're muted. Come on. What is your size up? If your size up is just painting a picture of the scene to see what you're dealing with, are there any interventions in there? Did I lose y'all? All right. Yeah, it's actually been about an hour anyway. There you go. What do you? So there are no interventions in your size up ever, right? Because your size up is just, that's your BSI scene safety stuff. So it's always the same, and there's nothing, you'll never do anything in it other than just put on your gloves, and the rest of it is just looking around and taking note of things. So keep that in mind. You know, your size up is easy. 6 steps, it's always the same. But your primary is where you start having interventions. What's an intervention that we can give to somebody that's having an oxygen issue? What can we do in our primary for something with that?
Give them oxygen.
Give them oxygen. What part of your primary? What letter?
A. Or
Sorry?
B.
B. There you go. Right. Remember, A is just the route. That's just making sure that the route's there. Now in a stroke, not all of their route is working, but the route that we're concerned about is just mouth and nose to lungs. And so we can definitely take care of that. Usually if they're still awake talking, that route is fine. So we'll give them oxygen, but at that point we're in B. So you've moved from A when you give them oxygen. All right. Circulation, if they're not bleeding out, there's really not a lot that we do for circulation. There's no intervention there. We're just checking to make sure that it's good. But when it comes to stroke patients, when you get to your secondary, there's going to be some extra questions that we're going to ask. Firstly, let's talk about the actual question, you know, OPQRC and all that. Of all the questions that you could ask your patient, which one do you think is the most important to ask a stroke patient? If you can only get one question out of either sample or OPQRSC.
No, I don't know.
Take a guess. It's okay to be wrong.
How long have they been like that?
Yes. Yes. And it's the weirdest thing. Like, why would that be the, you know, why not allergies or something like that? But at least for us, but the reason that we're asking that, the reason that's the most important thing is because stroke isn't something that we can fix, right? Even a paramedic can't do anything about a stroke. So the questions that we ask, the things that we do is all about what's going to happen at the hospital. And a lot of the stroke interventions that the hospitals can do, they're time sensitive. So if it's been more than 24 hours, some of the treatments don't work. They won't do them. I don't even know if they can do them. Like, I don't know if it causes harm or what. I don't work in stroke levels at that stage to know the actual thrombolytic contraindications, but if it's been over an X amount of time, they can't do it. So that's, if you're going to get one question, it's when were they last normal? That's the biggest thing, because that determines all of their treatment once they get to the ER. So keep that in mind. And then the rest of it is trying to figure out, are they really having a stroke? And so we use there's a bunch of them out there, but the one that's the most common, the one that we teach and that you see it out there is Cincinnati stroke scale. So you want to make them smile, grimace, hold their hands up, right? See if one's drifting or anything like that, and have them actually squeeze, check for their strength. If you think about, let me ask you this actually. Do you know the difference between Bell's palsy and an actual stroke? And how, like, as far as the signs in front of you, were to look at a patient, what would you see that's different? Because they look in the face, they look exactly the same.
Bell's palsy is just the face. The stroke is like their arms too.
Exactly. Yep. So Bell's palsy is just a face. That's a cranial nerve issue. It's not actually a stroke, but it makes the one side of the face droop. But a lot of people don't know that, and it's scary as hell when you wake up, you look at your spouse, and that's what you see, and you're like, oh crap, here we go. But they're fine from the neck down. They got good strength bilaterally. They can hold both hands up, no problem. Just facial droopage. That's Bell's palsy. That's not an emergency. That's it's just a nerve. It's like your arm going to sleep. It's a pinched nerve. They can go to the hospital, but it's not something that the ER is going to fix. It's not a thrombolytic issue or anything of that sort. And then let's see, what else did I want to cover? When in regards to the actual, like what you're going to see in your patient when you're doing your Cincinnati stroke scale, let's talk about left and right side. So when you assess your patient, if they have left-sided face droopage, which side of the body? All right, well, how about this? If the left side of the brain is affected, which side of the body is affected?
The right side.
The right side of the body. Which side of the face?
The right.
Good guess. So that's actually something that it's a misconception. A lot of people think that it's all the way down. We know that the left side of the brain controls the right side of the body, but for the cranial nerves, it doesn't switch. If your left side of the brain is affected, it's going to be the left side of the face. The switch is actually at the base of the skull. That's where the wires cross. So left side of the brain, left side of the face, but right side of the body. I'm not going to say that you catch people faking it with that, but sometimes they do. If they don't know it, they'll kind of droop one side of the face, but they also droop the same side of the body because they're used to hearing that, it's the entire thing all the way up, but it's not. It's the switch happens at the base of the skull. We don't teach that to try to get you to get students to find fakers. We teach that so that you don't think somebody's faking. When you go out to the real world and when you're dealing with people that do fake it, and you see that, you're like, nah, that's weird. It's supposed to be that way. It's just a weird little difference. But anyway, we're gonna call it. I don't want to lose you guys. I don't want to gloss your eyes over. I will do this again as we go through it. If you guys, like I said, practice those registry questions, put them in Discord, the ones that really trip you up, especially if either A, it doesn't give you a justification for the answer, or it doesn't make sense. Or if you just think it's a good question, something to put out there that we can talk about. That way we can kind of get you guys used to how the questions are written, because I'm finding that when I'm looking at pass rates and fail rates and what people are struggling with in the classes, I'm realizing that it's not the curriculum. You guys are coming out of this and y'all are rocking it.
Stop.
A lot of y'all know enough that you could, like, some of our recent graduates had enough knowledge of the curriculum. They probably could have taught the class, but the registry, the tests just kept flipping them out, like tripping them up. So that's what I want to focus on. Chris is teaching you guys curriculum. Chase is teaching the advanced EMTs curriculum. I know that they're doing a great job. So I want to focus on actually like test prep. Anytime you want to do it, I'll do it again, probably sometime either into this module or into module 4, and we'll talk about trauma. But I want to do it from a assessment perspective so that you can kind of see how the registry is going to be looking at it, because those 4 right answer questions, they're really not. It's just people aren't really seeing what the question is asking. But anyway, thank you all for showing up, and I'm going to go ahead and stop the recording for people who want to see this later on after the fact, and we'll do it again.